Coronavirus disease is an infectious disease caused by a novel beta-coronavirus known as severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. The disease associated with it is now referred to as COVID-19 feet. On December 31, 2019, the World Health Organization was informed of a cluster of cases of pneumonia of unknown cause in Wuhan City, Hubei Province, China. On March 11, 2020, the WHO announced a COVID-19 global pandemic due to the rapid spread and severity of cases worldwide. SARS-CoV-2 is felt to be zoonotic in origin, but the source of the original outbreak has not been identified. The original virus strain has mutated over time, causing new variants with differing abilities to spread and cause severe disease. Variants of concern continue to be identified, and a renewed WHO nomenclature was adopted on May 31, 2021 for COVID variants using the Greek alphabet, to make communication easier and to ensure labels were non-stigmatizing. The National Institute for Health and Care Excellence, ICE, provides the following definitions. Acute COVID-19 feet is defined as signs and symptoms of infection consistent with COVID-19 for up to 4 weeks. Symptomatic COVID-19 feet is defined as signs and symptoms of COVID-19 infection from 4 weeks up to 12 weeks. Post-COVID-19 syndrome is defined as signs and symptoms that develop during or after an infection consistent with COVID-19, continue for more than 12 weeks, and are not explained by an alternative diagnosis. It usually presents with clusters of symptoms, which may overlap, fluctuate, and change over time, and affect any body system. Longer-term effects of COVID-19 feet or long COVID defines signs and symptoms that develop during or after an infection consistent with COVID-19, continue for more than 4 weeks, and are not explained by an alternative diagnosis. It includes both ongoing symptomatic COVID-19 feet and post-COVID-19 syndrome. Note: this information is correct at the time of publication of this topic, but may change over time. For up-to-date information on the COVID-19 vaccination program, see the NHS England website, www.england.nhs.uk. Information Primary Care Guidance. Genetic analysis of SARS-CoV-2 shows that it is an RNA virus which is genetically distinct from SARS coronavirus, but shares some genetic sequences with bat coronaviruses in China. COVID-19 virus spreads from an infected person's mouth or nose by droplets, from sneezing, coughing, speaking, singing, or breathing. These particles range from larger respiratory droplets to smaller aerosols and are transmitted between people when they are inhaled or come into contact with the eyes, nose, or mouth. The risk of transmission is highest if a person is in close proximity to an infected person, especially within 2 meters and/or in a poorly ventilated indoor space. Indirect transmission may occur due to contact with surfaces contaminated with the virus, fomite transmission. Perinatal transmission has been documented. However, the exact mode of transmission is not known. The incubation period for SARS-CoV-2 varies depending on the circulating variant and is about 3 days for the Omicron variant. Several risk factors have been associated with an increased risk of severe infection and/or death, including increasing age, male sex, comorbidities such as obesity, diabetes, hypertension, severe asthma, and chronic obstructive pulmonary disease. Health and social care workers, lower socioeconomic status, Black, Asian, and minority ethnic, BAME origin. Clinical subgroups at highest risk of severe infection and/or death from COVID-19 infection include Down syndrome or other chromosomal disorders known to affect immune competence, certain types of solid cancer and/or receiving treatment for certain types of cancer, hematological diseases, e.g., leukemia, lymphoma, myeloma, myelodysplastic syndrome, myelofibrosis, sickle cell disease, and stem cell transplant recipients. Renal disease, including renal transplant recipients, non-transplant renal patients who are immunosuppressed, chronic kidney disease stage 4 or 5, liver disease, some forms of cirrhosis, especially decompensated liver disease, liver transplant recipients, liver disease on immunosuppressive therapy, other solid organ transplant recipients, Immune-mediated inflammatory disorders, including people taking some forms of immunotherapy, biologics, JAK inhibitors, corticosteroids, uncontrolled or clinically active disease. Major organ involvement, weakened immune system, common variable immune deficiency, severe combined immunodeficiency, HIV or AIDS, if immunosuppressed, have uncontrolled or untreated HIV, or acute presentation of AIDS-defining diagnosis. Neurological and neurodisability conditions, multiple sclerosis, motor neuron disease, myasthenia gravis, or Huntington's disease. Possible complications of COVID-19 infection vary, depending on the circulating variant, the person's age, comorbidities, and risk of immunosuppression, and may include acute respiratory distress syndrome. This is the leading cause of death due to respiratory failure. Venous thromboembolism. A hypercoagulable state may increase the risk of arterial and venous thromboembolism. Cardiovascular, most commonly heart failure, acute myocardial injury, acute coronary syndrome, and arrhythmias. Acute kidney injury may be caused by volume depletion, viral infection leading to kidney tubular injury, thrombotic vascular processes, glomerular pathology, or rhabdomyolysis. Acute liver injury may be due to viral infection, drug toxicity, systemic inflammation, hypoxia, or hemodynamic factors. Sepsis, pediatric multisystem inflammatory syndrome in children. This rare condition may present with persistent fever, signs of inflammation, and evidence of single or multi-organ failure. Multi-organ failure, neurological, may include acute stroke disease, ataxia, seizures, encephalopathy, encephalitis, meningoencephalitis, cerebral venous sinus thrombosis, peripheral neuropathy, and myopathy. Secondary bacterial pneumonia. Bacterial secondary or co-infection is rare, with an increased risk in people who are immunosuppressed. Long COVID. The prognosis of COVID-19 infection varies depending on the person's age, ethnicity, comorbidities, as well as the circulating variant. Most people with COVID-19 infection will have a mild to moderate respiratory illness and will recover without needing specialist treatment. People in highest risk clinical subgroups are more likely to develop more serious illness or complications. In the UK, seroprevalence studies have shown an increased infection fatality ratio, derived from combined mortality data with infection rates in older age groups. Symptoms. The incubation period for SARS-CoV-2 varies depending on the circulating variant and is about 3 days for the Omicron variant. COVID-19 infection can cause a spectrum of illness, varying from asymptomatic infection to mild upper respiratory tract infection, URTI, to severe pneumonia and other complications. Suspected diagnosis of COVID-19 if a person presents with a high temperature, fever, or chills. A new, continuous cough, frequent cough for more than an hour, or 3 or more coughing episodes in 24 hours. A loss or change to sense of smell or taste. Shortness of breath, feeling tired or exhausted, muscle aches and pains. Headache, that is unusual or longer lasting than usual. Sore throat, blocked or runny nose, loss of appetite, diarrhea, nausea and/or vomiting. Note: COVID-19 infection in children and young people under the age of 18 years is usually mild and a short-lived illness. Note: about 1/3 of people with COVID-19 are asymptomatic. Note: older and/or immunocompromised people may present with atypical symptoms, such as delirium and reduced mobility. For many people, the symptoms last between a few days and several weeks. For most people, symptoms resolve by 12 weeks. However, this is very variable. About 1/3 of patients don't develop any symptoms, and symptoms may last long after 12 weeks. Long COVID. If a person has a suspected or confirmed diagnosis of COVID-19, assess the person using face-to-face, telephone, or video consultations depending on individualized risks and benefits using clinical judgment. Assess for signs and symptoms suggesting severe illness and risk of early deterioration, such as progressively worsening breathlessness, severe difficulty breathing or breathlessness at rest. Consider reversible causes of breathlessness, such as pneumonia, pulmonary edema, pulmonary embolism, chronic obstructive pulmonary disease, and asthma, and manage appropriately. Hemoptysis, cyanosis, blue lips or face, feeling cold and clammy with pale or mottled skin, collapse or syncope, new confusion, drowsiness, reduced urine output. Hypoxia, reduced oxygen saturation levels measured by pulse oximetry. Oxygen levels of 92% or less in room air in adults suggests severe hypoxia. Oxygen levels greater than 4% lower than usual levels suggests severe hypoxia. Oxygen levels of 93 to 94% in room air in adults suggests moderate hypoxia. Oxygen levels below 91% in room air at rest in children and young people aged 17 years and under suggests severe hypoxia. Consider using exertion oximetry tests, such as the 40-step walk and 1-minute sit-to-stand tests, if oxygen saturation is at least 93% and the person is aged 65 years or more and/or at highest risk of serious illness, to assess for oxygen desaturation on exercise. A 3% or greater reduction in oxygen saturation level is considered significant. Note: be aware that some pulse oximeters may under or overestimate oxygen saturation levels, especially if the level is borderline. Levels may be overestimated in people with dark skin. Suspected COVID management. If a person has symptoms suggestive of COVID-19 infection, arrange hospital admission if indicated following clinical assessment. If hypoxia, reduced oxygen saturation levels, is a likely cause of breathlessness, consider arranging admission to secondary care. If there is severe hypoxia and/or the person is severely ill, consider arranging urgent hospital admission. If there is moderate hypoxia and the person is not severely ill, consider arranging hospital assessment, the urgency depending on clinical judgment. Arrange hospital admission or specialist referral if there is a suspected complication, depending on clinical judgment. If hospital admission is not clinically indicated. If a person is at highest risk of becoming seriously ill with COVID-19 infection, advise to take a rapid lateral flow test as soon as possible, even if symptoms are mild. If the initial test result is negative, advise to do 3 rapid lateral flow tests over 3 days. If a person is not at highest risk of becoming seriously ill with COVID-19 infection, advise to try to stay at home and avoid contact with other people if they have a fever and/or they do not feel well enough to go to school, college, childcare, or work, or do their normal activities. If a child has mild symptoms such as runny nose, sore throat, or mild cough and they feel well, they can continue to attend school, college, or childcare. Advise the person to resume normal activities once any fever is settled and they feel better. Advise on sources of information and support. If the person has been in close contact with a person with COVID-19. If they are a household or overnight contact of a person who has had a positive COVID-19 test result, advise that it can take up to 10 days for infection to develop. Advise on sources of information and support to reduce the risk of transmission to others, such as the NHS online resources. Advise on common new or ongoing symptoms after COVID-19 and expected recovery times. Reassure that for most people, symptoms resolve by 12 weeks. Confirmed COVID-19. If a person has a confirmed COVID-19. Management. If a person has a confirmed diagnosis of COVID-19 infection following a positive test result, if in an eligible group for testing, arrange hospital admission if indicated following clinical assessment. If hypoxia, reduced oxygen saturation levels, is a likely cause of breathlessness, consider arranging admission to secondary care. If there is severe hypoxia and/or the person is severely ill, consider arranging urgent hospital admission. If there is moderate hypoxia and the person is not severely ill, consider arranging hospital assessment, the urgency depending on clinical judgment. Arrange hospital admission or specialist referral if there is a suspected complication, depending on clinical judgment. If hospital admission is not clinically indicated and the person is at highest risk of becoming seriously ill with COVID-19 infection, advise that antibody and antiviral treatments may be offered in the community by NHS England if all of the following additional criteria apply. The person is aged over 12 years. The person is symptomatic and not improving. Note: treatment is indicated. Hospital admission is not clinically indicated and the person is at highest risk of becoming seriously ill with COVID-19 infection. Advise that antibody and antiviral treatments may be offered in the community by NHS England if all of the following additional criteria apply. The person is aged over 12 years. The person is symptomatic and not improving. Note: treatment is indicated. The person should be automatically contacted by NHS England within 24 hours of a positive test result. If this does not happen, arrange urgent referral to the local COVID medicines delivery unit, depending on local referral pathways. Advise on sources of information and support, such as the NHS website, www.nhs.uk, patient information on current treatments for coronavirus, including information on antiviral medicines and neutralizing monoclonal antibody medicines. If hospital admission is not clinically indicated and an adult is not at highest risk of becoming seriously ill with COVID-19 infection, advise to try to stay at home and avoid contact with other people for 5 days after the day the test was taken. Advise to avoid meeting people at higher risk of becoming seriously unwell from COVID-19 for 10 days after the day the test was taken. If a child or young person aged under 18 years is not at highest risk of becoming seriously ill with COVID-19 infection, advise to try to stay at home and avoid contact with other people for 3 days after the day the test was taken. Advise on sources of information and support, such as the NHS website. Advise on common new or ongoing symptoms after COVID-19 and expected recovery times. Reassure that for most people, symptoms resolve by 12 weeks. Hospital treatments. NICE currently recommends the following hospital treatments. Consider awake-prone positioning for people in hospital with COVID-19 who are not intubated and have higher oxygen needs. Non-invasive respiratory support. Do not routinely offer high-flow nasal oxygen as the main form of respiratory support for people with COVID-19 and respiratory failure, in whom escalation to invasive mechanical ventilation would be appropriate. Consider continuous positive airway pressure for people with COVID-19. They have hypoxemia that is not responding to supplemental oxygen with a fraction of inspired oxygen of 0.40% or more. And either escalation to invasive mechanical ventilation would be an option, but it is not immediately needed, or it is agreed that respiratory support should not be escalated beyond continuous positive airway pressure. Consider using high-flow nasal oxygen for people when they cannot tolerate continuous positive airway pressure but need humidified oxygen at high flow rates. Maximal conventional oxygen is not maintaining their target oxygen saturations, and they do not need immediate invasive mechanical ventilation, or escalation to invasive mechanical ventilation is not suitable. And continuous positive airway pressure is not suitable. They need a break from continuous positive airway pressure, such as at mealtimes, for skin and pressure area relief, or for mouth care. They need humidified oxygen or nebulizers, or both, or weaning from continuous positive airway pressure. Antivirals. Nirmatrelvir plus ritonavir is recommended as an option for treating COVID-19 in adults, only if they do not need supplemental oxygen for COVID-19 and have an increased risk for progression to severe COVID-19. Consider a 3-day course of remdesivir for children and young people who weigh at least 40 kilograms and adults with COVID-19 who do not need supplemental oxygen for COVID-19 are within 7 days of symptom onset and are thought to be at high risk of progression to severe COVID-19. Consider a course of remdesivir, up to 5 days, for people who have COVID-19 pneumonia and are in hospital and need low-flow supplemental oxygen. Consider a 5-day course of molnupiravir for adults with COVID-19 who do not need supplemental oxygen for COVID-19, are within 5 days of symptom onset, and are thought to be at high risk of progression to severe COVID-19. Sotrovimab is recommended as an option for treating COVID-19 in adults and young people aged 12 years and over and weighing at least 40 kilograms. Only if they do not need supplemental oxygen for COVID-19, they have an increased risk for progression to severe COVID-19, and nirmatrelvir plus ritonavir is contraindicated or unsuitable. Tocilizumab is recommended as an option for treating COVID-19 in adults who are having systemic corticosteroids and need supplemental oxygen or mechanical ventilation. Consider baricitinib for people 2 years and over in hospital with COVID-19 who need supplemental oxygen for COVID-19, are having or have completed a course of corticosteroids such as dexamethasone. Unless they cannot have corticosteroids and have no evidence of infection other than SARS-CoV-2 that might be worsened by baricitinib. Corticosteroids offer dexamethasone or either hydrocortisone or prednisolone when dexamethasone cannot be used or is unavailable. To people with COVID-19 who need supplemental oxygen to meet their prescribed oxygen saturation levels, or have a level of hypoxia that needs supplemental oxygen, but who are unable to have or tolerate it. Continue corticosteroids for up to 10 days unless there is a clear indication to stop early, which includes discharge from hospital or a hospital-supervised virtual COVID ward. Other treatments include prophylaxis of venous thromboembolism, the use of antibiotics only if there is evidence of additional bacterial infection and management of complications as applicable. Offer management for any symptoms such as breathlessness, cough, anxiety, and agitation. Assess and treat any underlying or reversible causes of symptoms, such as hypoxia, metabolic or electrolyte imbalance, co-infections, uncontrolled pain, urinary retention, and constipation. Consider prescribing a benzodiazepine first line to manage anxiety or agitation in people aged over 18 years. Seek specialist advice for people aged under 18 years. Treatments for managing anxiety, delirium, and agitation in people aged over 18 years. Anxiety or agitation and able to swallow, lorazepam tablets. Anxiety or agitation and able to swallow, midazolam injection. Delirium and able to swallow, haloperidol tablets. Delirium and unable to swallow, levodopa injection. Midazolam and levodopa do not currently have a UK marketing authorization for this indication or route of administration. COVID-19 immunization. Against COVID-19 provides modest but short-term protection, lasting a few months, against infection and mild symptomatic disease and transmission. Protection against severe disease and death appears to be greater and maintained over the medium term. COVID-19 vaccines are an area of ongoing research and recommendations may change as more data and other vaccines become available. Primary immunization. All adults and children who are aged 5 years and over on or before August 31st, 2022, are eligible for a primary vaccination course. Children who reach the age of 5 years on or after September 1st, 2022, are only eligible for vaccination if they are in a clinical at-risk group or are a household contact of an immunosuppressed individual. Children aged 6 months to 4 years are also eligible for a primary vaccination course if they are in a clinical at-risk group. In individuals with confirmed COVID-19 infection, vaccination should ideally be deferred until clinical recovery. However, during care home outbreaks, Residents with confirmed COVID-19 infection may receive the vaccine provided they are clinically stable. Ideally, vaccination of adults and children at highest risk of serious illness should be deferred until clinical recovery and at least 4 weeks after onset of symptoms or 4 weeks from the first positive PCR result, depending on clinical judgment. In patients with prolonged COVID-19 symptoms, consider deferring the vaccine if the patient is seriously debilitated, under active investigation, or has recently deteriorated, to avoid incorrect attribution of any change in symptoms to the vaccine. Most eligible individuals should receive 2 doses of COVID vaccine for their primary course. 3 doses are required for individuals aged 6 months and over who were severely immunosuppressed at the time of their vaccination. For most individuals, the Joint Committee on Vaccination and Immunization recommends a minimum 8-week interval between doses, unless rapid immunization is required in specific circumstances, e.g., individuals about to receive immunosuppressive treatment. However, for healthy individuals aged under 18 years who are not health and social care workers, carers, or household contacts of immunosuppressed individuals, a minimum 12-week interval between doses is recommended. Same COVID-19 vaccine should ideally be used for the entire primary course, where possible. If the same vaccine is not available or suitable, or if the first product received is unknown, a suitable available product should be given to complete the primary course. If the course is delayed, it should be resumed, but the previous dose should not be repeated. Contraindications and cautions. There are few people who cannot receive the Pfizer, BioNTech, Moderna, or AstraZeneca COVID-19 vaccines. If there is any uncertainty, seek specialist advice from the local immunization or health protection team. Do not give the same vaccine to people who have had a confirmed anaphylactic reaction to a previous COVID-19 vaccine. If a person received AstraZeneca vaccine, an alternative vaccine may be given in any setting, with observation for 30 minutes. If a person received an mRNA vaccine, seek specialist advice if there was a possible previous anaphylactic reaction. If there has been a possible previous allergic reaction to any component of the COVID-19 vaccine, seek specialist advice. Do not give the Janssen COVID vaccine if the person has a history of confirmed thrombosis with thrombocytopenia syndrome after receiving the Janssen COVID vaccine. Postpone immunization if a person is acutely unwell until they have fully recovered. This is to avoid wrongly attributing any signs or symptoms of acute illness, including COVID-19, to the adverse effects of the vaccine. If a person has a minor illness without fever or systemic illness, immunization should not be postponed. Vaccination of a person who may be infected, asymptomatic, or incubating COVID-19 infection is unlikely to have a negative effect on the illness. Prolonged symptoms of COVID-19 is not a contraindication to COVID-19 vaccine. If there is evidence of current deterioration, vaccination may be deferred to avoid incorrectly attributing any change in the person's underlying condition to the vaccine. Adverse effects. COVID-19 vaccines are black triangle drugs, and any adverse reactions should be reported to the Medicines and Healthcare Products Regulatory Agency using the Coronavirus Yellow Card reporting site. Common or very common potential adverse effects include local injection site reactions, e.g., pain, swelling, redness, tenderness, fatigue, headache, chills, myalgia, arthralgia, fever, lymphadenopathy, axillary, supraclavicular, or cervical areas on the same side to injection. Rare or uncommon potential adverse effects include myocarditis and pericarditis, onset typically within a week of an mRNA vaccine, mainly affecting people under 25 years of age. Most cases mild and stable. In most cases recover spontaneously without medical treatment. Presenting symptoms may include new onset and unexplained significant chest pain, tachycardia or tachypnoea, dyspnea, palpitations, dizziness, or syncope. If suspected, Refer to an emergency department if the person is acutely unwell, has severe symptoms, or is clinically unstable. Vaccine-induced immune thrombocytopenia and thrombosis has been reported after administration of the AstraZeneca vaccine. The majority of cases occur between 4 and 28 days following COVID-19 vaccine. Presents with unusual venous thrombosis, including cerebral venous sinus thrombosis, portal vein thrombosis, and sometimes arterial thrombosis. Symptoms may include new onset severe headache, may be worse when lying down or bending over, may be associated with blurred vision, nausea and vomiting, speech disturbance, weakness, dro, WEE, or seizures, new unexplained bruising or bleeding, breathlessness, chest pain, leg swelling, or persistent abdominal pain. If suspected, refer the person to an emergency department or arrange an urgent same-day full blood count. If not acutely unwell, and refer to an emergency department the same day if thrombocytopenia is CO. Guillain-Barré syndrome, very rarely reported within 6 weeks of AstraZeneca vaccination. Capillary leak syndrome, very rarely reported within 4 days of AstraZeneca vaccination in people with a previous history of this condition. Transverse myelitis, an adverse effect of the Janssen COVID-19 vaccine of unknown frequency. Dizziness, an uncommon adverse effect of the Comirnaty vaccine. Paresthesia and hyposthesia, an uncommon adverse effect of the Vaxzevria vaccine. Other adverse effects, unknown frequency, include heavy menstrual bleeding, Comirnaty, Spikevax, and cutaneous vasculitis, Vaxzevria. Pregnant or breastfeeding women. If a woman is pregnant, she is over the age of 18 years, the Pfizer-BioNTech or Moderna vaccines should be offered. If she is under the age of 18 years, the Pfizer-BioNTech vaccine should be offered. If she has already received a dose of the AstraZeneca vaccine, she can complete the course with the same vaccine or an mRNA vaccine. Routine questioning about last menstrual period or pregnancy testing is not required before offering the COVID-19 vaccine. If a woman finds out she is pregnant after she has started a course of vaccine, she may complete vaccination during pregnancy and should complete vaccination at the recommended interval. If a woman is breastfeeding. Advise, there is no known risk associated with a non-live COVID-19 vaccine while breastfeeding. Advise on sources of information and support.